Assalamu alaikum. Welcome everyone on board. Uh, the topic which we will be discussing is actually in a way that this question is being asked in a number of scenarios. Maybe it is a written exam, or you are working as a resident and the senior or consultant or senior registrar, whatever is with you, or senior resident is asking that we are doing this case or we are dealing this patient. So what are the concerns in this patient? Okay. So I will just try to figure out that how you can construct your answer. Not only because actually sometimes we are only thinking about the exam, but it's not only exam that you should be targeting. It should, your approach should be beyond that, that how you can be a good anesthetist, a safe anesthetist, because remember one thing, that anesthesia has very little anesthesia. Anesthesia has very little anesthesia, and it has everything which is actually not anesthesia. It is starting from the common sense, but it is looking at the patient from head to toe and looking at the aspects of anesthesia, sorry, the surgery, and the patient age group, patient comorbidities, or whatever you can name, that anything is related to anesthesia in one way or other. Even so, I just say by like weird way, that the care provided by the anesthetist is like care provided by a mother, and the care provided by anyone else, especially the surgeon, is like care provided by the father, because fathers are a little casual, but mothers are never casual, and they are, even if they are working, they have a one eye back at home. Okay, so this is what anesthetist is. That the anesthetist is looking at the patient in all the aspects, and same will be applied. This will be only applicable if you are able to chalk out all the risk factors, all the problems which you will be facing with reference to any patient. Okay. So usually it is in the form of three things which you always should be thinking. That one will be the patient group. Like it may be an elderly patient, it may be a pediatric patient, it may be a pregnant patient, it may be any. So one thing will be that patient group with reference to any change, with reference to any problem. And because some of the diseases are so common, that I will also consider it as a patient group, though it is not, it's a disease, but because these diseases are so common. So in my opinion, that you should be consider even those diseases. Can you, Dr. Naim, if you can just mute your mic, because I am distracted by it. Thank you. Okay. So this is what. So one thing is patient group, number one. The other thing which is important is the comorbidities. Okay. Comorbidities may mean with reference to, because I am just telling you an idea, and then we will come to the individual concerns, how to chalk them out. So one thing is patient group, other thing is comorbidities, or with the exam scenario, there will be certain disease which they will be asking you. Like for example, there will be a scenario that a 55-year-old male, known case of diabetes or hypertension, and for example, sickle cell disease, or for example, myasthenia gravis, or any extra thing. Okay, this is a scenario which you can get in even in Pakistani exam, but more so in international exams, in table viva or in long case. You will have I can just, for example, I'm telling you that in Irish fellowship exam, I had this scenario: a 55-year-old male, no, morbidly obese, okay, known case of diabetes mellitus and hypertension, and the associated, I will say, the comorbid, because this is, I'm saying, a group. So that was von Willebrand disease. Okay, and that patient was presented for laparoscopic hemicolectomy, okay, for CA colon. So that can be a sample, and then even in real time, usually you have things like that. Okay, so the third thing which I did not write here is surgery. So whenever someone is asking you what are the concerns, so you should be thinking about three things. Whenever this question is being asked, whether in the exam, whether this question is asked in the real time, whether even if you are planning as a resident, you should be dividing your task in three groups. Okay, and then you can go into the details that how will you chalk out or how will you see, because if you have multiple problems, there will be some things which will be common. Okay. Anyone who is going for Viva exam, so I can take that person as my target, who would want to speak out. uh, Usman, is it Usman Khalid?
Yes, sir, ma'am.
Okay, so just if we just so because among the patient group,
Samira will.
this. Okay, okay. So first of all, actually, because at the moment there are some people who are from other countries, so we will try to speak in English only. Okay, because I shared this link to other groups as well, where there are international people. Okay, so we will just try to speak out in English. And okay, so who speak out other than Usman? You, Marwa? Marwa, you speak. You raise the hand. Any one of you who are Viva candidates, just raise the hand. Or anyone who want to speak out, just raise the hand. I will just one by one I will ask. Okay. Zulfikar, is it Zulfi? Why are you hiding? Is it Zulfi from Al Hassa? Anyways, yes. So Usman, just if you I will correct yourself. So at the moment we will just try to concentrate other than surgery. There will be some concerns with reference to surgery. So if you want to, just can you just explain what should be the main points to think about in this patient? So how will you answer this question?
Um, so according to what I understood, this is a patient. This is the age 55 years old, I guess.
Yes.
A 55 years old patient is morbidly obese, and he has diabetic. He's diabetic, hypertensive, and he has von Willebrand disease, and he's on list for laparoscopic hemicolectomy because of CA colon.
Okay.
Okay. Sir, in this patient, my concerns will be patient-related concerns, surgical-related
First of all,
concerns.
I will just tell you that in our Pakistani exam in table viva, you will never have this case. Okay, so you can take it that you can take in groups. So diabetes will be one group, hypertension will be one group.
Okay.
Yes, obesity can come in that group, and cancer
Okay.
can be in one group. Okay, so one, two, three, four, five things. Okay, so you can
Okay.
just combine, or I think it is better if you can tell one by one. So first of all, if you just target obesity, what will be your
Obesity. Okay.
concern as an obesity?
Sir, in obesity, I'll ask about the history of any comorbids that the patient is having, which we already know that he's having three comorbids. Along with that, if patient is having respiratory issues or not, respiratory distress or not, because already we know these patients are having low FRC, and they can be hypoxic and hypercarbic, and along with that, as the patient is morbidly obese, he can also have that obesity related that hypovolemic hyperventilating syndrome. I forgot the name. Pickwinian syndrome, I guess. If I'm sorry if I'm wrong. Um, Along with that, patient must be have this patient can have respiratory issue, pulmonary hypertension, and if this is worse, then we can also see the signs of right heart failure and cor pulmonale in this, and which can further lead to liver related issues, and along with it can become a syndrome like picture, and um, along with that, in morbidly obese patient, we also have to take care of the position of the patient. In the surgical in the operation theater, we have to arrange a proper table for the obese patients, because they can need a bigger table. Than in monitoring, we have concerns. Um, uh, standard one, standard two monitoring, blood oxygen saturation, heart rate, and BP will be monitored, and temperature will be monitored. And for blood pressure, there can be some mismatch of the cuff. That we use for the as a non-invasive blood pressure monitoring. So it's better in the morbid obese patient. We should be using invasive blood pressure monitoring. And uh, these patients can be can have difficult airway.
Up till
So
now, sorry, I will have to interrupt you. First of all, you have taken a lot of time. This is the thing which
okay.
you have to correct yourself. And up till now, you have not told even one time OSA.
Oh, OSA, yes, yes, OSA, yes. I'll ask,
Okay,
ask
so you
about the
have
history
you
of
have you have
snoring.
told all the story, but you have not told the special thing which you need to see in a
Uh,
morbidly obese
exactly,
patient. Okay,
exactly,
so
sir. Yes, yes,
now
sir.
and another thing I will just correct. Rest of the things you are whatever you are telling is right because everything is written in the book. But now the target, the problem will be that you have to summarize it, because in whatever exam you are, if you are talking about table viva, is a little bit difference will be in the long case. Okay, but in long case, whenever you will have a very obese patient, he will have a lot of problems. Okay, so for long case, the approach will be a little different. But if you are talking about table viva, even if they don't
Mhm.
put anything else, because there is obesity can be asked, there is a scenario because there are articles on obesity in pregnancy. Once I was asked about it. Okay, so obesity in pregnancy, so obesity can be for a bariatric surgery, obesity for any surgery. Usually, obesity itself will be a tip of iceberg, and you have to go into it. There are certain things which are basics. So one thing, important thing were logistics. So you will just tell that logistics things was important thing. And as I mentioned to you, you have forgotten that I have mentioned in the previous discussions always that use the word in table viva. Use the word evaluate. I will evaluate the patient on the basis of history, examination, and investigation. Okay, and what will be your
Yes,
target? Your target will be that what are the things which can be there. So that will be, so you can again, because in table viva you don't have time to tell. You will say I will be ruling out OSA, I will be
yeah,
ruling out any organ dysfunction, especially which with the organs which are involved are lungs, heart. They are the main organs which are involved. But in if they are involved, then other. But mainly lungs and heart will be the main thing. Okay. So with reference to
okay.
OSA, how will you rule out? You will be you can use that. We can just have stop bang.
Stop time.
Okay. So stop bang, we can say snoring, tiredness, observed apnea, pressure, BMI,
Yeah, my
age, neck,
age.
circumference, and gender. Okay, so you can
Yes, sir.
say it is, for example, five, for example. So in that case, you will
Mhm.
go for sleep studies.
Yes,
Okay,
studies.
so
Yes.
you can just in this way you will can rule out. And then, for example, if you when you will use this word end organ damage, then you can tell that because it's a tip of iceberg. Gradually, what will happen that there will be retention of CO2, there will be effect of that one on pulmonary vasculature, there will be development of pulmonary hypertension, and then cor pulmonale can develop. And whatever other terminologies are there, obesity, hyperventilation syndrome, and cor pulmonale and Pickwickian syndrome, they are only for just to check your nerves. They are not the failure points, mind it. Okay, so main thing will
Okay.
be that what will be the main pathology which will be there because of obesity. There is sort of restrictive lungs disease pattern. Patient will be retaining
Mhm.
CO2, and then all the effects will be following it. So you will be, if you will use this word of end organ damage, you will
Mhm.
actually, the examiner can understand, and now you will be in a stronger position to explain that if whatever next question will be, you so the initial answer should be in a way that the examiner understand and takes you seriously. And this is only if you know. So now I will use a few seconds to explain to you this approach should be there, that you should make a half cut, half prepared answers for all the diseases. Because if you are just thinking that you will read a book And written, okay, written you can write the stories and whatever, you have time to think. But when you are sitting in front of few very dangerous people who seems to be a monster to you in the time of examination, now if you are not prepared for your answers before, you will not be able to compile that time. So my suggestion that make half cut answers for as many diseases as possible. I am just giving you an idea, and try to make what I even in the group of Viva I sent this message that try to make a 1 minute answer, 1 minute answer for all these categories. Okay, pregnant patient, pediatric patient, obese patient, diabetic patient, hypertensive patient, coagulopathic patient. And I had made, I will show you the list which I just made for you to make an answer. So that, the evidence for that one is that if you are cooking at home, you cannot make a delicious kadai or delicious food in 30 minutes. Okay, no woman can do it. But if same thing, if you are going to a hotel, they are able to prepare a very tasty food in 30 minutes. Why? How? Because they have prepared all the recipes in half cut way, as I am telling you, to prepare your answer. Okay. So my suggestion will be use this trick, and I can guarantee you that you will enjoy in the exam, because all of you know, and whosoever fail in the exam is not because they don't know. They fail because they are not able to understand the question, and they are not able to answer in an appropriate way. So the presentation matters. If you even if you have cooked very nice food, but you are not able to present in a nice way, your when you present in front of someone, it's just messy. So the other person, even if it's very tasty, will not like it. So same is true in the exam. So examiners have very little time to evaluate you, so the presentation is very important. Okay, and another way, if you are in order and you are trying to tell the most important things at first and go to the less important thing later on, and as an anesthetist, which things are important for you for the conduct of each step of anesthesia. If you are not missing those points, I can guarantee you will never be failed. Okay. So this is the main theme which you should never forget about it. So OSA and organ damage, and then the rest of the things which you told, the logistics issue, you need more manpower, you need a bigger table, you need, because this patient will be at risk of DVT. So you will always try to initiate whatever you can to prevent DVT. Then this patient is at, like, then will be then you can, if you have reached up till that moment, then you can tell a number of things, that you will try to give the anesthesia medications in a way who have less metabolism, who have less respiratory depression, who have less hangover. Plus, because these patients, if these patients have pain, they will have splinting, and if they already have some baseline respiratory or cardiac problem, that will be exaggerated. These patients, if they have a risk factor, you will try to observe them in HDU or ICU. So these are the things which you have to tell, and this is common in whatever surgery you are going through, almost, at least in abdominal or thoracic surgeries, or like laparoscopic surgery, or any surgery in which there is pain. Even the surgery is not upper abdominal or thoracic, but there is a lot of pain, that will cause splinting, that will cause the same effect which you will have. Yes, it will be more in abdominal surgery or thoracic surgery, but it will be there. Even if there is pain, there will be splinting, and there will be all the consequences which are there with reference to respiratory system. Okay, Usman, I hope you understand.
Yes, sir. I understood.
Okay, so investigation, as we
Yes,
had discussed before, so you will be looking at the ABGs, you will be looking at chest X-ray, you can, but there should be some indication. You will not do ABGs in every patient. If you see that stop band criteria is higher and there is AHI index is more, so you will try to optimize. The elective surgeries will be postponed. You will try to have some optimization, but a cancer surgery or any urgent surgery or anything which cannot be cannot be delayed, then of course you will have to go through with the risk stratification. Okay, and with reference to monitoring, as you told, that you will have, in addition to standard 1, standard 2 monitoring, you will have special reference to, you can have arterial blood pressure monitoring in case you don't have the appropriate BP cuff size. Okay, it will be a big challenge for you. IV lines will be challenging. If it is too much obese patient, airway management will be challenging. So you can tell about ramp position and use of glidoscope or fiber optic, whatever. Now, if you have things in your mind, then you can make your answer. Like this patient will have aspiration, more aspiration risk, difficult airway. So now, if you know the points, the starting the starting points, then rest of the answer will be easy for you to prepare. Okay, so now you can just think about all the steps starting from pre-medication. You will not give too much sedation. Aspiration prophylaxis you can consider, DVT prophylaxis you can consider, ICU you can consider, monitoring logistics I have told you. Then anesthesia medications, you will try to use the medication which does not have too much hangover or too much metabolism or too much respiratory depression. So morphine will not be a good choice. You will try to use non-opioids, or you will try to use regional anesthesia in a way. Okay, so similarly you can go.
Epidural for,
Sorry.
epidural for analgesia.
Yes. Okay. So if you use the, yes, you remind me of this thing, that with reference to epidural or regional anesthesia, what you should be telling, 2 points you should be telling.
First of all, we'll be using the long needles,
Very good.
spinal
Number one. Number two.
epidural,
Number
and
two.
it can be, and we'll give slightly less dose because of the engorged vessels
No,
and
one more thing with the performance.
So
We
use
will
of
go.
it's the expert. We can use the
Sorry.
ultrasound, and only the expert anesthetist will be doing the procedure.
Yes. Who was speaking? Sadia, you were saying something?
yes, sir, I was saying that use of ultrasound will be helpful in this
Okay.
case.
So ultrasound, how? What will be the advantage? What you will be targeting with the
Yes,
ultrasound?
sir. With ultrasound, we will target the midline first of all
Very
because
good.
it will
Number two.
it is, and then the depth of the space, epidural space.
Very good. And three, one more thing you can see. Very good. Think. These 2 points are valid. You will see where is midline. You will see what is the difference from the skin to the space. And the third thing is you can count the vertebra.
Yes,
Okay,
sir.
because
Yes.
sometimes it with a big fat pad you are not able to identify which level you are. Okay, so right now I will just tell you a fact that only 1/3 you are at L3 L4, because you are putting your hands there and you think you are at L3 L4, but you will be surprised to know that international data suggests that you are 1/3 time you are in that level, 1/3 time you are up, and 1/3 you are down. So if you are down, it's not that much serious issue. But if you are up and then you are thinking that you started at L2, L3, and now you are going one step more up, so you can enter in some danger zone. Okay. So this is the importance of it. So we have just discussed this thing as well, that ultrasound, use of ultrasound for central neuroaxial block, what your targets and what is the significance. So we are covering obesity, but we have discussed these things as well. Okay. So with reference to OSA, you have to look into this stop bank score, and then you will go for AHI, and you will label it according to the apnea-hypopnea index. You will label it as mild or moderate or severe OSA. Okay, and accordingly you will handle. So this is the main points about it. Investigation, rest of the investigation will be like any other cardiac or liver or whatever end organ damage is there. You will explain accordingly. Okay, not that all obese patients has ESOSA, and not that only not all thin patients cannot have AOSA. Okay, even OSA can be there the patients who are not obese, because of some which will be that group with OSA without obesity.
So a patient who are having enlarged tonsils, adenoids,
Very good.
and
For
uh,
any patient with bulbar weakness, can they have OSA?
yes, sir, yes.
Okay, so this will be a separate which will have obstruction. Okay, so these are few things: obesity, history, examination, investigations, stop bang. There may be are some other things, and then the rest of the things: logistics, monitoring, um, I almost post-operative ICU, use of neuromuscular monitoring. Uh, Patient should be extubated, fully awake.
Patient might need CPAP for the post-op,
Might
so
need
we also.
post-operative CPAP,
Yes,
HDU, as I told you. Okay, so these should be the things which you should be taking care of. Okay, so that,
yes.
and then if you summarize this answer, if you summarize answer as an concern, try to use minimum words. Try to squeeze the answer in a words that they are very compact. That you will be evaluating the opacity. First of all, of course, I did not mention here. It will be morbidly obese obesity. You should be knowing the class 1, class 2, class 3. They can ask you about BMI, how to calculate it. It's a very simple question, but they can ask. So you should be prepared for it. Okay, and then your answer, if you use this stop bang, it will be very helping you a lot. So stop bang, then AHI, and then so that's how you can target obesity. Okay, so the next thing which was there in this scenario was diabetes mellitus. Okay, so uh, Marwa, you want to speak out?
जी सर
Okay, please.
सर सिनेरियो एक दफा रिपीट कर दें मेरा
Uh,
डिस्कनेक्ट हो गया था
okay, so you are just answering, you are just trying to have a patient who is diabetic for any surgery. Just
नहीं
think
सर
about it.
अच्छा sir I will evaluate the patient on the basis of history examination and investigation to look for the severity of end organ damage involved due to microvascular and macrovascular diseases and glycosylation of joints leading to difficult airway and look for any reversible component if present to optimize it or
Very good.
concerns. My anesthetic concerns will include glycemic control. A patient can be in मतलब acute complications को prevent करना है glycemic control को आपने manage करना है difficult intubation होगी due to glycosylation of joints increased risk of aspiration है during anesthesia exaggerated stress response है to laryngoscopy during extubation and incision there are chances of silent ischemia and we should avoid nephrotoxic drugs,
Very good.
which
Okay.
include NSAIDs.
Okay. So
Um,
very good, because you have practiced it. So your answer is quite good, but I will just try to even improve it further. That you were saying microvascular and macrovascular disease. It's not macrovascular macrovascular disease. It microvascular and macrovascular
complications.
complications of diabetes mellitus. Okay.
Yes, sir. Yes,
So
sir.
then you did not mention about the treatment, the medications. Okay, so you can say there will be some effects because of the medications patient is taking. Okay, there are I don't remember
Mhm.
exactly. There are some problems with chronic insulin injections. There is some skin changes or something like that, and oral hypoglycemics. They have their own side effect. Like even if you are talking about non euglycemic agents, there will be some effects like lactic acidosis or some renal problem, and the other hypoglycemic agents, they have their own side effects. Okay, so you should be
जी
just,
sir.
you can just you used few words about it, and the rest of the thing, glycemic control, with reference to how you can use this, that glycemic control we can monitor through which test? Hemoglobin A1C.
HbA1c.
Okay, so glycemic
हाँ
control
जी.
through HbA1c, and the microvascular and macrovascular complications, you can just tell that they are retinopathy and nephropathy. Okay, and
Right. हाँ जी.
Mm,
this autonomic neuropathy. Okay, so for
Peripheral
retinopathy,
neuropathy.
yes, retinopathy can be
Autonomic.
by like fundus examination. Okay, and nephrotoxicity with
हाँ जी
reference to albuminuria. Okay, and
हाँ
this
जी
urine complete and with the ultrasound. Okay, and autonomic neuropathy, you
हम्म,
can have signs with reference to exaggerated autonomic reflexes, and there are a list: fixed heart rate, and I forgot all of the gastroparesis. Can someone chalk? Can
postural
you remember?
hypertension,
Postural hypotension, number one. Okay, what else? Fixed. Uh,
increased risk of aspiration.
this gastroparesis. Okay,
हाँ जी
Resting
and
tachycardia.
resting tachycardia. What else?
um,
There are few decrease RR
Autonomic.
variability. RR variability. The normal variability will be decreased. Okay, so you can just, because these points, you can, I am telling you a format, so you can fill the cramming stuff, you can do it. So these are 3 4 5 things which you should be knowing with reference to autonomic nerve, because what will happen when you will use this word, as I'm telling you, they can stop you and they can ask you in detail. So this answer is the further a little bit detailed answer. With reference to difficult airway, try to use difficult airway rather than difficult intubation, because difficult airway will cover in difficult intubation, difficult laryngoscopy, and difficult back mask ventilation. Because of glycosylation of joints, not only the problem will be in the with reference to intubation, there can be problem in the ventilation as well. Okay, so this will be a thing. And uh, macrovascular complication, what will be them? What will be
This
the
coronary
atherosclerosis.
artery.
Okay, so it will be atherosclerosis, which will be affecting the heart, which will be affecting
Stroke,
Stroke.
TIA,
brain. We are trying to use the organs, and then third one is vasculature,
Vessel.
peripheral
vasculature.
vasculature. Okay, so in the heart,
Hmm.
it will be in the form of ischemic heart disease. Ischemic heart disease will be in the form of arrhythmias or angina or MI or heart failure. So these four things can occur. And with brain, it will be TIA or stroke. Okay.
Stroke.
And peripheral vasculature, it will be
जी
ischemia or gangrene or
diabetic foot.
diabetic foot, yes, but or ischemia, gangrene, or this intermittent claudication.
Hmm.
Okay. So in this way, if they want to have detail, initially you just use this word: atherosclerosis affecting heart, brain, and vasculature. And then you can tell in
Hmm.
detail with reference to according to the severity and the involvement of the coronary vasculature. There may be arrhythmias, there may be angina, there may be MI, and there may be heart failure. Okay. So this will cover everything, believe. So now then you can tell in detail about the investigation. In the preceding sessions, we have discussed in detail about the investigation. If I will have to be a little quick so that we can cover some other scenarios, but a number of things will be the same. You will be doing ECG.
Hmm.
Then if it is indicated,
Hmm.
then you can go for stress testing. Then you can go for echo. Then you can go for thallium scan. If still there is some need, you can go for angiography. So this is the step:
Hmm.
ECG, and then if there is some sort of arrhythmias, you can go for Holter. Okay, so this
Hmm.
will be the five. I will just write quickly: ECG, resting or ETT, then echo, again resting or dobutamine stress, then X-ray, then uh, thallium scan. Again, it is this is stress thallium. Okay, and then there are some additional thing which you should have in mind. Don't speak out unless they are asking you cardiac CT, because they will see the patency of coronary vasculature. But this is advanced thing. I'm not I'm sure that they will not ask you, but you should be knowing about it. And if there is any form of arrhythmias, Holter, and then you again, this is just a stock answer that you should be knowing if there is any problem with the any abnormal focus. They go for electrophysiological study, and they can do radio frequency ablation, but don't tell unless they are asking you. But I'm just giving you an idea how to proceed with it. Okay, and if there is any problem with the coronaries, so the next thing will be angiography. Okay, so angiography, then they can, it may be negative, or then after that they can put a bare metal stent, only balloon angioplasty. Okay, or they can go for drug eluting stent, or they can decide that this patient is not for percutaneous cardiac intervention, and they have to go for cabbage. So this is the sequence of events of all the cardiac problems which you can face. And another thing which I will tell right now, so that you can understand that like you use the word silent ischemia. So if you don't have good physical activity, then you have to go for stress testing. So because in this scenario or any other place, they can give you a scenario in which the patient does not have good physical activity. So physical activity, if is not there, you cannot rule out ischemia. And in because in diabetic patient, maybe there will be no angina, but still the coronaries are affected. So you have to go for stress testing, so that you put the heart on the stress and see how it goes. Okay, so this is an important thing which you should not miss. And actually, there was some other thing which was clicking my mind and it slipped out. I was just telling something else which I just forgot. Anyways, so this is how you will be targeting. Okay, and okay, so with reference to brain, so it will be either it will be TIA or stroke. Okay, so one thing will be CT scan. Okay, and then other thing will be carotid Doppler or this CT angio. Okay, I am, because in the CT angio is not available in all the centers, but CT angio, I was, in my opinion or my understanding before, carotid Doppler would be a better thing, because CT angio is telling you a static situation. Okay, at one moment. Or however, with carotid Doppler, you can have the pulsatile flow. How is it going? So, but anyways, because it's a specialized job, so I got an answer from one of the neurosurgeon, or I was just discussing the case. So they say that CT angio is gold standard. So I'm not sure about. I did not check the data, but you can check about it. I don't think so. You will be asking. You will be asked in details, but you should be saying that it will be CT scan and carotid Doppler or CT angio, or with reference to clinical signs and clinical symptomatology, with reference to sensory system, motor system, higher mental function, any cranial nerves, and autonomic sensory and motor system. Okay, so this is how you will be evaluating. And for this one, peripheral vascular disease, again, clinical sign symptoms and the Doppler studies. And if there is any need, they can go for vascular intervention. Vascular intervention can be open, or vascular intervention can be endovascular. So this is just a concept to understand, if you have this problem, what can be the possible answers, or how they will be asking you. So this is with reference to the macrovascular microvascular complication in diabetes. The very important thing which is asked a number of times. Yes, you know what I was about to tell and forget. Now I recall what I was telling. So actually that was intraoperative MI. Okay, in the same scenario, whether it is diabetes or any heart problem, they can ask you about intraoperative MI. So with reference to intraoperative MI, maybe how just I ask this question to you: how can you pick intraoperative MI? Yes,
ECG changes.
ECG
Hemodynamic
changes.
changes.
ECG changes, hemodynamics, okay.
Mhm.
ECG in the form of ST depression, elevation, ST
Yes, sir.
changes,
ST
and
changes.
arrhythmias.
Mhm.
Arrhythmias,
Yeah.
okay. Patient can have VF or patient
Mhm.
can have PVCs, okay. But the problem is that the
Mhm.
maybe ST changes or arrhythmias, they are not too much clearly defined. So hemodynamics can be there, and then usually we just look at the sweating or things like that. So sometimes actually it is very
Mhm.
difficult to pick intraoperative MI, believe me, it's very difficult. So
Mhm.
like you have to go like you have to be very like your like you should be looking for it whenever, because sometimes they are using cautery and using constant cautery and you are not able to pick it. How will you pick the change? This is one thing. Then maybe you are giving any patient hypotensive anesthesia and you are not able to identify that this hypotension is because of your medication or the patient has already heart has failed. So sometimes even if there is hypotensive anesthesia and you are not giving too much this one ventilation, and then end-tidal CO2 is reciprocally less. So this can alarm you that the cardiac output is decreased. Then physical touch of the patient. Okay, physical touch of the patient is very important. As I told you that one of the things is sweating, but rest of the things I told you. Then another important thing, if you have intra-arterial blood pressure monitoring, the waveform can tell you a number of things. So that may help you. Then the next step will be that if you have any suspicion, then you will go for cardiac enzymes. So it will be CKMB or CPK or prop props
Transesophageal echocardiography.
prop T and prop I. Very good. Transesophageal echo. Of course, you can say they don't use the word that, because say if you have expertise and available, then transesophageal echo is a gold standard to identify what is the word for that segmental wall motion abnormalities. Okay, so that is the answer, because whenever there is ischemia, the first thing is segmental wall motion abnormality leading to hypokinesia and then akinesia and then failure. Okay, so this is the sequence of event that even transthoracic can give you some information, but I'm just giving you a picture real time. I'm not telling you from any book. This is the real time that what can be there. Now if you have any doubt, what should be your answer? That immediately you will go call for help. Then what will you do? 100% oxygen. Then what will you do? And immediately you will call cardiologist. Okay, then what else you can do? You will stop surgery if possible. You will try to reduce the stress, and then two few things you can do, and you can tell one of them is heparin, one of them is aspirin through NG. Okay, and then opioids like morphine. Okay, so our very old formula Mona. So one thing is missing is nitrate. Another thing you can do is beta blocker, or these are all options. All these findings or all these options will be according. You will not give, for example, if you say you will use beta blocker without telling that if the situation is like that, that you can give beta blocker, only then you can tell. Otherwise, no. Otherwise, no. Okay, because MI can be with high blood pressure. MI initially, if maybe there is a stress, you do the laryngoscopy, the blood pressure became 200, and because this blood pressure was heart was not tolerating, or patient went into tachycardia, and patient did not tolerate, heart did not tolerate, and have ischemia. So initial period there may be hypertension, but ultimately if heart is going in failure, there will be hypotension and hemodynamic collapse. So it's an actually open answer, and you can say you will immediately call the cardiology, and further management will be the discussion with the cardiologist. These options may be required to be used. The blood pressure is high, you will try to reduce the blood pressure within 20 to 25% of the limitation. So that's how you can answer this question. It's a sort of
So we
critical
can say that we will maintain the myocardial oxygen supply and demand.
Very good. This is the answer which I forget. I tell all the time, you will maintain the myocardial oxygen demand supply ratio. Okay. You will try to avoid all the factors which can increase the requirement and decrease the supply. Okay. So yes, I forgot to mention this thing. So this is, and then another thing, which is actually my best friend will come, which I tell many times: oxygen, CO2, temperature, volume, pressure. Okay, so avoid hypoxia, avoid hypercarbia. This is a questionable thing. Uh, would you like to have normothermia or hypothermia?
Normothermia.
Normothermia. Okay.
Normal of
Actually, if there is cardiac arrest, then it will be hypothermia. Okay. Now, rather it is not clear hypothermia. You will not you will try not to have hyperthermia, because hyperthermia will increase the oxygen requirement. Okay. So this is how you will proceed. And then another thing, multimodal analgesia. Okay. This word which I have written is in my file which I have made. I have just write it as my best friend. So avoid hypoxia, avoid hypercarbia, avoid hyperthermia, avoid hypovolemia, avoid swings of blood pressure. And then 2, 3 more things you can tell: sinus rhythm, SVR, maintain SVR, maintain preload and afterload. Okay. And the very good word for it is maintain right and left heart filling pressures. Okay. So this is what all good anesthesia is. So in this scenario, you can explain the situation in that way. Okay. So what else is left with reference to diabetes? Yes, very important. Diabetic control. Okay. So we have discussed this before as well, but because we are discussing this case. So for gastroparesis, you have to give acid prophylaxis. For difficult airway, you can tell about rapid sequence induction or modified rapid sequence induction. Okay. And again, according to the end organ damage you have, you will do the things which are involved. You will try to protect, as was mentioned by Usman, that you will try to avoid nephrotoxic drugs. Okay. Nephrotoxic drugs are all the factors which can be a renal risk factor. So how much mean blood pressure you should be maintaining in that patient, in this patient with diabetes? What should be the mean
more
blood
than
pressure?
65.
Sorry?
More than 65?
You are wrong, Usman. Correct your
80?
concept. Sorry?
80,
Sorry?
sir, 80.
Yes. So the answer is between 80 to 180 is for kidneys. And this one you are using is 60 to 160 for brain. That's
Yes, sir.
why if you have hypotension in a trauma patient or any other things like that, the kidneys will shut down. Okay. So kidneys shut down at a higher at a higher limit than brain. So there will not be hypoxia in the brain, but there the urine output will be decreased because kidney needs higher pressures. So you can tell that because like diabetic patient is at sort of according to the diabetic patient can be as fit like our hero Wasim Akram, and diabetic patient can be anyone. So not all diabetic patients are alike. So but you can have to mention few of the, you can tell about contrast, and you can tell about NSAIDs. So if you just use this word, that any medications which can affect the kidneys with that respect will exaggerate the already impaired renal functions if it is there. So this is one thing. And yes, diabetic control. So there are certain basic rules for with reference to diabetic control is that you have to stop the long acting and you have to convert into short acting. Okay, this is one thing. Then another thing will be that fasting blood sugar, if it is more than 180 or it is less than 180, this will be milligram. So if it is more than 180, you can give half dose of insulin, regular insulin. If it is less than 180, you will skip it. Number one. And then your target blood sugar is you around 120 to 150, or you can say it is loose glycemic control. Loose glycemic control you should have. And then you have to monitor 30 minutes to 1 hour blood sugar. This is another important thing. Then you have three options. You can have subcutaneous. Number one, you can have intermittent IV bolus, or you can have IV infusion. Okay, subcutaneous is not a very good choice because of altered hemodynamics resulting in altered absorption. So subcutaneous is not a good choice. IV bolus versus IV infusion. Better is IV infusion. You can control, you can stop, or you can, but still you can use IV bolus as well with the sliding scale. Okay, so the preparation can be different. There are some pre-formed mixtures which are prepared already with the electrolytes and sugar. Okay, and like electrolytes, especially potassium. Okay, and the insulin. So a rate is written and you can control. This is the simplest of the answer. Believe me, if you tell these things, you are pass. Then they are asking you some different difficult questions which I don't remember even. I have forgotten because it's totally non-practical thing, and actually they should not ask, but still they are asking this GIK regime or Alberti regime, or I don't remember. So you can cram about it, but my suggestion will be that start your answer like that our target is to have loose glycemic control, because tight glycemic control is not
So
there is a risk
what
of
is the
hypoglycemia.
range?
Yes,
So what is the range of this loose glycemic control and strict glycemic control?
it
I
is,
don't.
yeah, it is around 120 to 150. Okay,
The strict one and the loose one is
no, this is loose one.
okay.
Strict was 80 to 120. It was
80
around
to
100. So that was resulting in that can, if you are giving insulin and it has more effect, so it can cause. So insulin may be regular insulin, or it's Lispro ultra fast acting. Okay, so that's how there are different insulin regimes. Sorry, different insulin preparations. You can have a look. In intraoperative, you never use NPH or you never use glargine, because they are intermediate acting or
long.
long acting. So these are none of your business. But for long case, you should be knowing about it. You should be knowing everything about insulin. You should be knowing everything about oral hypoglycemics, because this they will ask you. But the more important thing, what is the mechanism of action, and what is the side effects? If you are very unlucky, they can ask you even the preparations. I'm not sure what they want to get from it, but I remember we were told that they can ask you about Dimacron and they can ask you about Getril. And so if you are very unlucky, they can ask you, but I don't think so they will fail you on this question. I never went up to that thing. Okay, because in my opinion,
Excuse
if
me,
they
sir.
fail me for this thing, I accept my failure, because this is nonsense. They should not be asking about the preparations, but still you will find some of the examiners who will be concerned about preparations. So if you can know a few of the preparations which are available, it maybe because I cannot say by guarantee. Still, there will be some examiners alive in Pakistan who will be asking these questions. Okay.
So the most common question asked about oral hypoglycemics is about the because we have to know that which drugs have to be stopped and which drugs do not need to be stopped in the perioperative period.
So short
So
acting,
short
this is one
acting,
thing.
long acting, yes.
Short acting and long acting. Okay. So usually these drugs which are being used now, they are not long acting. There were some other this I forgot the names even. Actually, there are some of them.
Sulfonyl ureas are to be stopped.
Sulfonide, yes, sulfonyl
While
urea,
the
some of them are long acting. So for theoretical purpose, that's why I'm telling you, I don't remember. So I am sorry, I'm deficient in it, but you should be knowing about it. And another thing that you can make in two groups, that one is like metformin and one are like this sulfonyl ureas. Okay. So there are 3, 4 groups, but some of them are like insulin. One of them, few of them are insulin secretagogues who are increasing the insulin secretions. Okay. And few of them are increasing the sensitivity. They are not increasing the insulin secretion. They are increasing the decreasing the resistance and increasing the sensitivity. So these medications will not cause that much hypoglycemia as compared to the ones who are secreting insulin. Okay. So insulin secretagogues will be hypoglycemic agents, and usually the other medication will be hypoglycemic euglycemic agents, and some of them have effect on the GI tract to decrease absorption of the carbohydrates. Okay. So these are the 3 of the things which you should be knowing. Am I right,
सर
Zishan?
pre-op period में
Yes.
सर pre-op period में हम लोग oral hypoglycemics
Can
को
you
जिस
speak
तरह
in
normally
English,
stop
Marwa? Marwa, sorry to interrupt you.
जी
Please,
सर
can you speak in English? There are some people who are from other country. Yes, please.
जी सर सर as we stop our oral hypoglycemics
Yes.
preoperatively in our hospitals and shift it to insulin on sliding scale. So
Okay.
can we tell this regime or not?
Yes.
मतलब by
You know,
stopping.
I'm sorry, but
no,
I
not at
don't
all.
understand. Zishan, sorry, Marwa, can
Sir,
you repeat?
she's saying that in her hospital they stop all the oral hypoglycemics and convert every patient to sliding scale insulin. So she's
Okay.
asking that can I answer this question, this answer in the exam or not?
Uh, actually, this is not wrong answer, Zishan, because usually oral
But the
hypoglycemics
sir,
are
the
stopped.
guidelines and the books are telling us that we don't need to stop biguanides. We just need to stop the sulfonyl ureas.
Mhm.
And there was another group that we need to stop. Otherwise, the other ones like uh, these newer drugs, Galvus, etc., and these bigonide, etc., these are not to be stopped. They have to be continued.
You are right, but I'm telling you that this because you have also a valid point, and her point of view I'm supporting in that way, that usually insulin effect can be predictable. Okay, so whatever patient was taking before, if you stop it and now you control wholly solely with insulin, so that's not a wrong answer. Okay, your point is also valid, that they are not needed to stop. So these are two different things. So you can say that we can follow the smart answer will be that if we continue according to the hospital policy, we can continue, but in some hospitals they rely wholly solely on insulin, so it will be an individual decision. Okay. If they are asking you till that, Marwa, so I think Zishan point is also valid. You can say that usually the euglycemic agents can be continued. You can use this word, and hypoglycemic agents should be stopped, because in perioperative period, oral hypoglycemic agents effect you cannot predict. So it is better not to use them. So that's the answer, in my opinion. Okay.
Okay, sir. Okay.
Try to remain simple. If they are peeping through too much details, again, try to answer in a diplomatic way. Okay. Because if you are in one dimension that you say that we will stop, then maybe they can catch you. Or as Ishan told, that they can be continued. So in that way, you have the chance to change the party. But if you do a press conference, then it will be difficult for you to go back. So try to be diplomatic. Try to put your feet in both sides, so that you can use your, if you think you see in their eyes that they want this answer, so you can change your statement. Okay. So actually, this is just your mental strength which you need when you are when you are appearing in the exam. Okay. So that's how I think we have covered majority of the things. And another thing which I just forgot with reference to nephropathy, that you have to tell about, in addition to the normal monitoring, you have to tell about urine output. I forgot. I just struck my mind at this time, so I just telling you. Any questions? Any questions up till now? Yes, Usman, Sadia, Marwa.
No, sir,
I
it's clear, sir.
I'm sorry.
Sir, everything is clear, sir.
Okay, so usually these will be the questions, even the same things which we have discussed. If they are asking in long case, then they will ask you in detail, and you have to ask in history, examination, and investigation. And if they are asking you this question in the table viva, you don't need to go in too much details. You just tell in points that these will be the things you will be looking, and that's how you will be, because the table long viva long cases questions, in addition to what we have discussed, is define diabetes mellitus, what is the diagnostic criteria, okay, what is the, even they can ask you about how this microvascular and macrovascular complications occur. So you should be just knowing about the basics, how this autonomic neuropathy occur. If I'm not wrong, there is some involvement of the vasculature of the nerves, so then the nerves are damaged and there is neuropathy, this because of this thing. If I'm not wrong, just correct me, because these small tiny concepts you are prone to forget. But you should be, for the long case, you should be knowing this. You should be knowing the diagnostic criteria with reference to HbA1c, with reference to fasting blood sugar, okay. And then you should be, the rest of the things I have already mentioned in detail. So I think I will stop here, and inshallah in next sitting, because my suggestion again will be that try to just build up your concept in that way, that whatever they are asking you, you are able to answer. Actually, I don't think, know where is it. So the list of the, just a second, because I keep on making the lists and questions and everything, only because even Zishan says to me that you should make a schedule, but unfortunately, because of my busy routine, I'm not able to make a proper schedule for it. So pardon me for that thing, but I just try. Yes, this was a list which I shared to you people in this one of the group. I did not share in the all the groups, but you can practice pregnant patient, elderly patient, pediatric patient, neonate, premature, obese, diabetic, hypertensive, smoker, alcoholic, drug addict, steroid dependent, cancer patient, generally cardiac patient, CLD patient, CRF or dialysis dependent patient. You can have, I will share this link to all of you. But remember one thing, that you will have the scenarios like this. So it is better if you prepare your answers before. 30 seconds answer, 60 seconds answer, and then you should be knowing how to explore it further. Okay. So thanks a lot for sparing the time to attend the class, and inshallah we will have some more sessions. So
Sir,
yes, Ishan.
I did share a schedule with you. Just
Yes,
scrolling my messages.
but unfortunately, I don't have, I couldn't dare to implement it, Zishan, unfortunately, because of my routine, my health. There are so many things going around, and unfortunately, if you take if you are able to help me out, we can have a schedule, because I know that if I'm not there, you can conduct the class. Okay, because you are there with me, because I will appreciate Zishan, that Zishan is among few of the people who are with me even after passing the exam, because all of other people pass the exam and then run away, and I'm never able to find them where they are, though they just leave me alone. Okay, so I'm thankful to some of the people which I can say from other countries, Dr. Mona, Dr. Ghada. Okay, so I will be very happy to, I think Kizia, I'm not sure from which country you are. You used to have some people from African countries attending this is a big honor for me, because I'm not taking these days regularly, and because of my routine. And again, I told you, because of my health, I have chronic backaches and chronic aches. So I need your prayers. so that I'm able to have this thing continued. And Zishan, you are absolutely right. He actually, I will share the schedule in the group and let's see what happens. So, unfortunately, I'm not able to conduct
Actually,
these things on a
I
regular
tried
basis.
to keep it very less number of classes, like twice a week only. Any day, you select any day, but twice a week, an hour or two session. It will be covering most of the things till the
Okay,
exam.
okay, we
But
will,
now
Zishan.
already some time has passed. Hmm.
Yes, you're right, but I will try to implement it. But as I told you, I was traveling a few times in previous 1 or 2 months. So unfortunately, I was not able to do it. Okay, so thanks a lot, all of you. But my mobile is ready to attend any of your question anytime. So don't hesitate to ask anything anytime. Remember one thing: the best way to learn is to teach. So if you want that you don't forget what you have learned with hard effort after you pass the exam, please keep on sharing with others. So this way you will not forget and the other people will get benefit. I am only doing this thing. Believe me, of course other people get the benefit. But if you are saying, I'm telling you the secret, that the biggest advantage for me is that I appeared in any exam about 7 years ago, about 6.5 to 7 years ago. And if I'm able to recall or I'm able to speak out again and again the same word which I learned, and I have not lost my efforts, this is only because of all of you. Okay. So despite very few people attend the classes or very few people are in touch with me, I again and again invite you that try to, wherever you are, try to help others, try to teach others, try to speak out, and don't be reluctant. Okay, because
Sir,
if a person,
in this exam, I'm seeing that it's encouraging that 3-4 people are participating well in today's
yes,
session. Like there were 3-4 people that
yes.
were participating. In the last exam, I saw that no one was participating. That was, of course, very
Actually, I
disappointing.
also couldn't get the time. Anyways, thanks a lot, all of you. Special thanks to Zishan and all of you. Bye bye. Assalamu alaikum.